Greetings everyone, and welcome to the knee module of ultrasonography of the musculoskeletal system. When you look at the knee, you could actually break it into two parts, the extraarticular portion of the knee and that of the intraarticular portion. Let's look at the extraarticular portion, but first telling you that the ultrasonography of the knee involves evaluation of the tendons, the ligaments, the bursae, and as you can see on Netter's cross-sectional imaging, the multiple bursa around the knee. You appreciate the suprapatellar recess, which itself is known as the suprapatellar bursa, and that is the window to the knee, as you can see that it communicates throughout the rest of the knee. And as you go to the front of the patella, you have the prepatellar bursa. Further down, a little bit more inferior, you have the infrapatellar bursae, the superficial one in front of the patellar tendon, and the deep infrapatellar bursa just posterior to the patellar tendon. Behind the knee, of course, over here you see a supracondylar type of bursa, but even more important, although not shown here in Netter's drawing, is going to be the Baker's cyst, which will include as the intraarticular portion of the knee. After getting to know the bursa, we're going to be looking at the synovia further on, and last but not least, of course, for the intraarticular portion of the knee, we're looking at the cartilage. Today, with the extended field of view of ultrasound, you can appreciate the fidelity of ultrasound grayscale imaging to the known sectional anatomy presented by Netter. Starting from the top, you see the multi-pennate structure of the distal quadriceps muscle, merging itself into the musculotendinous union or junction, into the fibrillar pattern of the distal quadriceps tendon, to the bone acoustic landmark of the patella, back again to a fibrillar pattern of the patellar tendon, and inserting into the bone acoustic landmark of the tibial tuberosity. The grayscale imaging shows you a bit of the pennate structure of the quadriceps muscle at the musculotendinous junction, into the fibrillar pattern of the distal quadriceps tendon, into the bone acoustic landmark of the patella, and back into a fibrillar pattern known as the patellar tendon, and into its final insertion into the anterior tibial tuberosity. Behind the suprapatellar region, you'll notice the triangular suprapatellar fat pad separated from the prefemoral fat pad by a small amount of fluid, physiological fluid, in the suprapatellar recess, much like what we see in Dr. Netter's drawing, from the suprapatellar fat pad to the prefemoral fat pad to a tad bit of fluid in the suprapatellar recess. Below the patella, right behind the patellar tendon, you have Hoffa's fat pad, again showing the complete resolution that we can appreciate between Dr. Netter's drawing and our grayscale imaging. If you look at the long axis view with an extended field of view, you can also catch the portion of the knee and thigh in a short axis view. Here you could note on the grayscale imaging the equivalent counterpart of Dr. Netter's drawing. First, the bone acoustic landmark of the circumferential femur. Here you can see it on Dr. Netter's drawing. Around the femur, in a short axis view, because it's short axis view, then you can expect a styrene pattern of muscle is the vastus intermedius. To the medial aspect, you have the vastus medialis, and then you have the vastus lateralis. Dr. Netter's drawing shows a little whitish tendon because the rectus femoris is represented more as a tendon in comparison that we chose a level where we're showing muscle of the rectus femoris. Another way to look at ultrasonography in a modular approach is to look at the regions. Here you have the anterior knee, the medial knee, and the lateral knee. This will entail all the extraarticular structures. Later on, we'll include the posterior knee, which includes most of the intraarticular structures, including the posterior horns of the menisci and Baker's cysts. Let's start again on the extraarticular structures of the knee with an anterior approach looking at the quadriceps tendon. With the quadriceps tendon, putting the transducer in a long axis view, identifying the bone acoustic landmark at the base of the patella, then we should be able to duplicate exactly what the cross-sectional anatomy wants to show us. Here you see the bony acoustic landmark of the base of the patella, the fibrillar pattern of the quadriceps tendon, the suprapatellar fat pad, and you also appreciate the femoral condyle with hyaline cartilage, and an imperceptible suprapatellar recess. When afflicted with some lesions, the quadriceps tendon ordinarily will start with some degenerative changes or acute traumatic changes of tendinosis. Here in the long axis view, in an extended field of view, you appreciate that as the quadriceps tendon inserts into the base of the patella, you've lost the fibrillar pattern that you were expecting. But not all of it, because here you see only the anterior portion shows this thickened fusiform hypoechogenicity of the distal quadriceps tendon, representing the rectus femoris portion of the tendon. And if you go a little bit more posterior, you begin to see the fibrillar pattern of the vastus intermedius. So this region or segment is relatively preserved. On short axis view, you again confirm and build your confidence to the fact that it is a focal affliction of the rectus femoris portion that's affected because of the fusiform hypoechoic thickening in comparison to the relatively preserved bristle pattern of the vastus intermedius, and behind it is the equally or almost as hyperechoic fat of the prefemoral fat pad of the femur. When you have a tear, the fibrillar pattern is completely disrupted. Here you see in a long axis view where you were expecting some fibrillar patterns, a hypoechoic cleft transecting all the way from the bony acoustic landmark of the femur to well above the bony acoustic landmark of the base of the patella, representing fluid tracking through the suprapatellar recess across the tear of the quadriceps tendon into the prefemoral portion. Note the relatively preserved suprapatellar fat pad. This is on long axis view, and on short axis view, now you begin to realize the fact that the hyperechoic tendon is now being torn away from its muscle junction by a hypoechoic cleft of hematoma and fluid cutting clearly from the suprapatellar recess all the way to the skin surface. The most commonly affected portion in the patients that we have in our institution includes the quadratus portion of the vastus medialis. So this is the first region that most of us would like to take a peek at. Let me show you first in long axis view a normal tendon of the distal quadriceps. Here you see the pennate structure of the muscle, and as it joins the fibrillar pattern of the tendon, you have the musculotendinous junction. Note the clear and pristine fibrillar pattern of the distal quadriceps tendon as it inserts on the base of the patella. Behind that, you have the triangle of the suprapatellar fat pad and the prefemoral fat pad with a moderate amount of suprapatellar effusion. But if you look at a torn quadriceps tendon, you'll notice that you no longer can appreciate that fibrillar pattern. Instead, where you have a measurable gap of a discontinuous quadriceps tendon tear, you could see that there is a herniation of the skin into that gap. This is actually more like a clinical sign that the clinicians would appreciate in the ER. As imagers, we see the proximal stump of the torn quadriceps tendon and the distal stump of the quadriceps tendon, resulting in a downward displacement of the patella, known as patella baja, and it's now exposing almost the entire convexity of the femoral condyle. Knowing musculoskeletal ultrasound and MRI gives a lot of people healthy respect of the baseline radiographs of most of these patients. Note that on the lateral radiograph of the knee, the left knee, a quadriceps tendon tear is easily suspected because of the suprapatellar effusion. Then you have a disruption of the patellar silhouette and a widening of the soft tissue outline on the external portion of the knee. But immediately on ultrasound, you can appreciate the fact that you can identify immediately a measurable gap, usually filled with hematoma, and identify the proximal stump from the distal stump. This is a classical example wherein you note that the tears of the distal quadriceps tendon usually will involve 1 or 2 centimeters right above the patella. Now, from the long axis view going to the short axis view, note that now you have a separation of the tendon from the musculotendinous junction, and also clearly you can appreciate the hematoma collecting and separating the two stumps in a cross-section view. Let's move from the distal quadriceps tendon to the patellar tendon. If the knee is more extended than flexed, you will create some anisotropy of the patellar tendon. You'll appreciate that there is some hypoechogenicity in the infrapatellar portion of the tendon, and also as it inserts into the anterior tibial tuberosity. Simply have your patient flex his knee a little bit more, and in the same patient, as you can appreciate here, now we see throughout its entire extent the homogeneous fibular pattern of a normal patellar tendon. The most common lesion that most of us would see would be a jumper's knee, which is degenerative or overuse disease of the proximal portion of the patellar tendon as it leaves the apex of the patella. In MRI, you may see increased intensity subjacent to the apex of the patella, while on ultrasound, remember that we are looking for that fibular pattern. Instead, in its place, we see this fusiform hypoechoic thickening of the tendon and loss of the fibular pattern. What's interesting about the jumper's knee is more often than not, if you look again at the same patient on short axis view, you appreciate the fact that you'll see this nodular thickening eccentric, in this case, to the medial portion of the knee or patellar tendon, and it does not involve the entire patellar tendon. The other thing that you'd also appreciate is that the inflammatory or degenerative changes of this disease will now extend into Hoffa's fat pad. So patellar tendinosis, after you've identified it, take a closer look at what's happening, because well within the substance of the patellar tendon, you begin to note that there is lakes or vacuoles being created, representing now true intersubstance partial thickness tears or mucoid degeneration. The other thing you'll notice is that because of its proximity to bone, and bone is an active organ and it likes to react to violent instances. Note that what used to be a crisp bone acoustic landmark of the apex of the patella in this patient with chronic jumper's knee now shows some cortical irregularity. Jumper's knee is again the fusiform hypoechoic enlargement of the proximal portion of the patellar tendon, and on short axis view, as noted, you see that it is more or less eccentrically affecting and not the entire tendon. What is important with these individuals is to confirm indeed that it is hypervascular with the neovascularization of this overuse syndrome in these individuals, and confirmed on power Doppler in this case. The adolescent equivalent to jumper's knee is known as Sinding, Larsen, and Johansson disease. If you look at the upper left-hand image with the radiographs, you'll notice that there is a cortical disruption, cortical disruption at the apex of the patella. This is not a fracture. Here in a 16-year-old Norwegian boy in Oslo, Norway, the first image we actually encountered was the ultrasound image, where you see that there is a fissure or fragmentation of the apex of the patella and fusiform hypoechoic thickening of the proximal patellar tendon. Because this was a very promising varsity athlete, of course, we went ahead and asked for an MRI. Here you could see the increased intensity of the proximal patellar tendon subjacent to the apex of the patella, with mild signal changes involving the cortical portions of the patella. Patellar tendon rupture usually will occur almost just like the quadriceps tendon, about 1 or 2 centimeters from the patella. Note that on the MRI image, you'll have increased signal intensity of the proximal portion of the patella, accompanied by slackening or even telescoping of the tear. On ultrasound, you have loss of the fibular pattern. You have a measurable distal stump from the proximal stump, which is near at the apex of the patella. An artifact, which is the refractory artifact, helps us a lot with ultrasound because this identifies the edge of the stump. Likewise, on ultrasound, it was easier to identify the high-level echo representing the heterotopic ossification in these individuals in comparison to the MRI, which was a tad more difficult and retrospectively identified after we've done the ultrasound as a signal void within the distal stump of the tendon. A discontinuous patellar tendon will have a measurable gap. In its place, you'll have a hypoechoic hematoma. One more time, the edge of the proximal and distal stumps have this refractory type of artifact that will help you identify a true tear in these tendons. The short axis view, of course, clearly now shows that what we expected to see as a bristle pattern of a tendon is almost occupied completely by this hypoechoic hematoma with some fluid trickling around the anterior portion of the patella. It's not uncommon to have a diffuse patellar tendon tear. Notice that the entire fibular pattern is disrupted, and well within it you'll have longitudinal striations or separations of the fibers. In addition, you can appreciate that indeed it's a tear because there is some herniation of Hoffa's fat pad into the posterior portion as the tendon decompensates and the distal stump again allows more of the fat to herniate into this defect. Same patient now on MRI, a little bit more difficult to appreciate the distal portion of the affliction because of the lack of increased signal intensity, but again the change in contour helps for the confirmation. Likewise, on the fluid sensitive axial images here at the patellar distribution, you'll see the complete intersubstance changes afflicting this diffuse patellar tendon tear. The bursae are very important and they're virtual spaces. The prepatellar bursa, if you're not careful, might be completely effaced merely by the weight of your transducer. Here you see the bony acoustic landmark and a virtual space of the prepatellar bursa. As you go further out now, here in an illustration, notice that it is eccentric towards the apex of the patella. On radiographs, you'll see the soft tissue swelling overlying the patella. On ultrasound, definitively, you begin to appreciate the distended bursa and that of the synovial lining of these bursa. So when you have prepatellar bursitis, aside from identifying the fluid, take a look at what's happening to the synovia. The synovitis accompanying this prepatellar bursitis in this patient in long axis view and in short axis view tell us that there is not only the proliferative changes of bursitis or the synovia, but also the dirty subcutaneous fat, as you can appreciate it in somebody with gouty arthritides and gouty bursitis. This is a great case to illustrate why sometimes in the ER it's very difficult to identify if the patellar tendon is intact because of the overwhelming soft tissue swelling, as you can see here. Here in hemobursitis, not only is the superficial infrapatellar bursa distended with uncomplicated fluid, but also it tracks all the way to the prepatellar bursa itself. But clearly you can appreciate that it's all extraarticular subcutaneous and does not affect the intact patellar tendon. Sometimes you'll get to see a deep infrapatellar bursitis right behind the patellar tendon. Here you see the fibular patterns of the distal patellar tendon and behind it a distended sac of the deep infrapatellar bursa. Distal patellar tendinosis, probably in younger individuals, better appreciated as an Osgood-Schlatter's disease. You not only appreciate the fusiform hypoechoic thickening of the distal patellar tendon, but you also begin to appreciate the fragmentation of the apophyses, and of course, now you see the distended infrapatellar bursa. On long axis, readily seen, but also on short axis, especially for the fragmented apophyses. We're going to skip that part, okay? Let's now look at the two sides, the medial collateral ligament and that of the lateral collateral ligament. Ligaments connect bone to bone, and so from the femoral condyle to the neck of the tibia, you connect those 2 points, you begin to see the trilaminar portion of the medial collateral ligament. Trilaminar because you have a hyperechoic superficial layer, and then you have a hyperechoic deep layer. In between the two, you appreciate the relatively hypoechoic fibroareolar layer of this medial collateral ligament over the joint line. So this trilaminar structure stretches from the femur to the tibia, likewise appreciated on Netter's drawing at the bottom of this slide. Medial collateral ligaments are readily torn when there's especially some valgus stress on the knee. First, let's look at the unaffected side, where you see the intact superficial layer, the deep layer, and the relatively hypoechoic fibroareolar layer. In comparison to the affected side, notice that there is a large collection of fluid, in this case acute or subacute blood, separating the superficial layer from the deep layer in somebody with an acutely swollen medial collateral ligament or strain. Medial collateral ligaments like to tear at the femoral level, as you can see here, with the disruption with this hypoechoic cleft separating the superficial layer from the deep layer, both in long axis and in short axis. Because these are wide sheets, they actually tear in a zigzag fashion. Note here the bone acoustic landmark of the femoral condyle and the tibial condyle separated at the joint line. Where you're expecting a trilaminar structure, now you have hypoechoic disruption at the femoral level and that of the tibial level. Of course, relatively preserved in the center, you could see some slackening of a trilaminar structure. That's because medial collateral ligament tears like to zigzag. For confirmation, it's not uncommon from the ultrasound study to go ahead and look at the MRI images. Here in the MR image, as you can appreciate clearly, that there is a disruption of the femoral level of not only the superficial layer, but here, floating in the breeze, flaying in the breeze, is the deep layer of the medial collateral ligament. Let's now jump to the tibial level on the MRI coronal image, and you could appreciate the torn portion of the superficial layer, and again, blood in between these two, approximating exactly what we were appreciating on the ultrasound image. When you have a high-level echo, this represents the heterotopic ossification or dystrophic calcification of Pellegrini's theata. On your left-hand side, you see the intact trilaminar structure of the medial collateral ligament. On the abnormal side, which is in the right-hand part of the slide, you'll see this high-level echo with posterior acoustic shadowing representing the Pellegrini's theata lesion. We'll skip the pes anserinus, okay? The lateral collateral ligament, again, is bridging between the femoral condyle to the head of the fibula. In a small field of view, we see this fibrillar pattern of the lateral collateral ligament as it crosses the joint line of the femur and tibia. Netter's drawing shows you clearly that it takes off from the femoral condyle going into the fibular head. So with an extended field of view that one can employ in ultrasound, here you can appreciate the fact that the pacfibrillar pattern now connects all the way to the head of the fibula. Tears of the lateral collateral ligament like to occur at the tibial level rather than at the femoral level, just opposite of that of the medial collateral ligaments. So you'll see this hypoechoic gap, and of course in its place you have the hematoma, clearly identifying what's going to be the distal stump from the proximal stump. The iliotibial band is a wide sheet of aponeurosis that starts from the pelvic iliac crest all the way to Gerdy's tubercle. So as it goes down to insert into Gerdy's tubercle, you can place in a long axis view your transducer in order to identify the pacfibrillar pattern of the iliotibial band. Iliotibial band syndrome, very common in long distance runners and bicyclists, will show that there is some bursitis de novo at the level of the femur, but also some hypoechoic edema affecting the iliotibial band proper. If acute, you might even see some fluid around the subcutaneous region. So for the extraarticular portion of the knee, remember that ultrasound is exquisitely great for the extensor mechanism, which includes not only the quadriceps tendon and patellar tendon, but also the patella proper itself. And don't forget that the extensor mechanism does include the retinacula, both lateral and medial. These also can be diagnosed quickly with ultrasounds for any tears or strains. Remember that the collateral ligaments have been shown nicely on ultrasound and how quickly we can diagnose using ultrasound when we have any diseases affecting these ligaments, especially for sports injuries and trauma. Thank you very much for your attention.